So I'm going to be talking about a couple of different diseases, none of which are particularly new, but all of which have some developments. And then I'm also going to be talking about a couple different diagnostic procedures. So first, I'm going to cover equine neuroaxonal dystrophy and equine degenerative myeloencephalopathy, abbreviated as ENAD and EDM. So these are actually quite old diseases. They were identified in the 1970s by Dr. Mayhew, and subsequently has been identified as both an inherited neurodegenerative disorder that's linked to environmental vitamin E deficiency. So this disease, Uh-oh. We good? Okay. This disease has been described for a long time now, but it's fairly difficult to identify and diagnose, and it was ignored for about 30 solid years in the veterinary literature. So I'm going to describe to you the clinical signs. So these horses are neurologic with symmetric ataxia and conscious proprioceptive deficits that occur in all four limbs. Like this horse, they often have an abnormal stance at rest, and that's those conscious proprioceptive deficits. They have both weakness and spasticity, so they might be toe dragging, but they also might have some hypermetria in their forelimbs and in their hind limbs. The hypermetria is particularly evident in their forelimbs. You'll also notice that during the neurologic exam, this forelimb hypermetria is really exacerbated when their head is elevated. The ataxia is moderate and generally graded at 2 out of 5 or greater, though as the disease progresses, they can have more severe ataxia. So this ataxia develops within the first 1 to 2 years of life, but may go completely unnoticed until the horse is put into training or until the training is stepped up. Ataxia with hypermetria is classic for equine neuroaxonal dystrophy, but there are some really variable clinical signs that have been reported mostly in quarter horses. And so this doesn't occur in every case of ENAD or EDM, but in quarter horses particularly, we've noticed a reduced menace response. So you can do your menace, the horse moves away, but they fail to blink their eye. And they can see, they're visual, there's no change in their visual acuity, but they have this different menace response. Quarter horses are also reported, and Lusitanos are also reported to have a depressed lack of fight or flight response. And so a lot of times it's kind of misidentified in the quarter horse world as this is a great horse, right? It's very mellow. You can do anything you want to this horse. And then as it turns out, as their training goes along, some ataxia is identified. So I've got a video of this. So this video is a yearling quarter horse thoroughbred cross with ENAD that was subsequently confirmed on histopathology. This foal was the offspring of a clinically normal thoroughbred stallion and a quarter horse mare with clinical signs of ENAD, who'd previously had offspring with ENAD. So the foals were housed with other normal mares, and the foals were kept on a vitamin E restricted diet, which is quite easy to do in California. You can see in this video that this yearling has a spinal ataxia, but I want you to pay particular attention to the hypermetria. So circumduction of the hind limbs, toe dragging, and then you can see in the forelimbs, there's this hypermetria. Now it's tough to do a neurologic exam on this age group, right? It's difficult, but these things were really consistent with this horse. Some circumduction in the hind. And then Dr. Finno is going to walk off, and you'll see there's the forelimb hypermetria there in the forelimbs. So this just looks like spinal ataxia too, right? So there's some signs that might kind of clue you in to this being ENAD or EDM, but it's really clinically indistinguishable from the other diseases that can cause spinal ataxia. So we'll come back to that. Why do these neurologic deficits happen? So ENAD and EDM are neurodegenerative diseases that result in the loss of functioning neurons within the caudal brainstem and the spinal cord. Spheroids or degenerating axons are found in the spinal, found within the caudal medulla oblongata in horses with ENAD, while horses with EDM have more widespread lesions that also affect the spinal cord. Now, you might be asking yourself, why do lesions within the medulla cause conscious proprioceptive deficits in the limbs? And that's because the nuclei that are specifically affected by these diseases are the centers of control for discriminatory touch for the limbs. And so they're receiving and processing the information about where the limbs are in space, and then telling the spinal cord how to move the limbs. So if there's lack of neurons, then that information is not being relayed. So more diffuse lesions that we see in EDM are found within the spinal cord. So this is a section of a horse, a Lusitano, with spinal cord disease and equine degenerative myelopathy. And the arrows are pointing towards the axonal degeneration. So everything should be this nice purple color, but where there's loss of these functioning axons, there's symmetrical kind of pink staining. And that's evidence of EDM. And those are the spinocerebellar tracts that, again, control motor input to the forelimbs and the hind limbs. This image is from a paper from the Finno group of Lusitano horses with EDM. This image is from the same paper, and it's an extreme close-up of nuclei within the caudal medulla. This nucleus, again, receives sensory information that it then relays to the cerebellum. And the cerebellum, remember, is the area that says no. It elicits fine motor movement. And so the spasticity that we see in these horses' gaits is because of the lack of a functioning medulla. So we've got, you can see just kind of these Swiss cheese-like lesions. And so this is a degenerate vacuolating neuron. Here, that neuron's been replaced with this kind of protein-like matrix. And so this can be seen if you look for it in the right places in horses with ENAD and EDM. How common is this disease? The answer seems that it's actually really fairly common, but you have to look for it. So currently, we can only give a definitive diagnosis of ENAD and EDM on post-mortem exam with a pathologist who takes care to take sections from the affected areas. And as I said earlier in the presentation, this disease was first described by Mayhew and De La Junta in the 70s. They organized a prospective study at Cornell University and performed necropsies on 81 horses that were diagnosed with spinal cord disease, and found that EDM was actually the second most common diagnosis. More recently, we have a retrospective out of California with 316 horses. These horses were euthanized as a result of neurologic disease. And again, ENAD was the second most common diagnosis, coming in behind compressive myelopathy. Importantly, to remember in this study, no diagnosis was identified even on necropsy in 56 of these horses with neurologic disease that were euthanized because of neurologic disease. So that really hits at home how difficult neurologic disease can be to diagnose, even with excellent pathologists, excellent clinicians, and a really attentive necropsy. And it also tells us how much we have to learn about neurologic disease in the horse. So this is a people who do pedigree analysis are just amazing to me. This diagram is looks exceptionally complicated, but what it's basically showing us is that the cause of ENAD and EDM is multifactorial. So close pedigree analysis has identified that this disease is heritable, but that certain environmental conditions affect the expression of the neurologic phenotype. Initial studies were a bit delayed and hampered until the role of vitamin E was first identified as an independent variable. So this figure is a pedigree analysis from quarter horses, a group of quarter horses who were all living in vitamin E deficient conditions. And it was determined that in this family, that quarter horses living in a vitamin E deficient pasture displayed the clinical phenotype of ENAD in an autosomal dominant pattern. So you only need one copy of this gene to display this neurologic disease if the diet is also deficient. Some additional studies on ENAD and EDM have determined that oxidative damage causes the degenerative lesions. And so there's kind of other studies that corroborate these findings. So vitamin E, obviously a potent antioxidant, deficiency of that can result in this disease, but they've also identified some risk factors such as being exposed to different types of chemicals, high oxidative chemicals, and then housing in dirt lots, which are probably the risk factor is that they have no vitamin E, because the best source of vitamin E for the horse is green grass. So, though the pathophysiology and genetics of this condition have not been fully understood, it has been determined that by supplementing the genetically susceptible horses, both the incidence and the severity of ENAD can be decreased. So in the experiment that I described earlier with these purpose-bred foals to mares that were affected by ENAD or EDM, we were able to rebreed these mares and supplement the foals and the mares with vitamin E, and these foals had no clinical evidence of neurologic disease, which is pretty fantastic. We did find, however, when we were doing pharmacodynamic studies of the vitamin E that these foals were receiving, they seemed to metabolize the vitamin E at a faster rate. So they excreted it in their urine at a faster rate, and their serum levels did not increase as rapidly as normal non-ENAD and non-EDM foals. So this led us to the conclusion that quarter horses and likely other breeds with ENAD have an increased rate of vitamin E metabolism as compared to normal horses. In fact, these horses, like I said, have been found to metabolize and excrete vitamin E faster. Because of that, and because this happens when the foals are developing, low serum vitamin E is not a consistent finding in all cases. So if you have a mare and foal who were deprived of vitamin E during the important window of neurologic development, but are then shipped out to Virginia and put on green grass pasture, that foal may develop neurologic signs, but by the time you see it, might have a normal vitamin E level, and that's important. Though the vitamin E can help you, a low vitamin E can help you in the diagnosis of ENAD and EDM, it does not necessarily have to be present for that diagnosis. So important to remember that ENAD and EDM aren't the only diseases that are brought on by a low vitamin E, and some horses with low vitamin E have multiple different vitamin E deficient diseases. Equine motor neuron disease is also called by a low vitamin E, may occur alone or in conjunction with EDM. Clinical signs are very different than ENAD though. They're characterized predominantly by weakness, symmetric muscle atrophy. These horses have a bit of a stand on the ball kind of a stance, and they might even, in the more severe forms, be recumbent more often. They might even have some muscle fasciculations. Often they'll just weight shift, so they're really hard to keep them standing still. And that's because they have diffuse atrophy of the postural muscles, and the postural muscles in the horse are working basically all the time, or they should be working all the time. And so a lot of baseline oxidative damage happens there. And if there's no vitamin E to ameliorate that oxidative damage, then over time you get atrophy of those muscles. Some horses as well, and this has been identified mostly in warm bloods, but probably also occurs in other breeds. About 30% of horses with equine motor neuron disease also have this funny pigment retinopathy in the back of their eye. I actually saw one of these this year, or I suspect it to be, and it's a really cool pattern. It looks like a reticulated or honeycomb type pattern. This picture is beautiful. It doesn't quite do it justice though. So you can see this, we've got this pigment deposition in this honeycomb pattern. You need a dilated fundic exam to do this, but man, it's pretty remarkable when you see it. And nothing else causes this pattern. So that's a sign to you that even if the vitamin E is normal in this horse now, it in its past has had some vitamin E deficiency. No visual deficits, yeah, which is pretty remarkable. Yep, they've done electroretinograms, all kinds of visual testing in these horses, and their vision seems to be fine. Yep. Yep. What else was I going to say about this? I was going to say that unlike ENAD and EDM, which are really pretty hard to diagnose in the living horse, equine motor neuron disease has a way to get a definitive diagnosis, and that's through the sacrocaudalis dorsalis muscle biopsy. This is a bit of a tricky muscle biopsy to do. If you're going to do it in the field, Dr. Valberg has a fantastic description of how to do it on her website. She's at Michigan State now, and she's got a beautiful pictures and description of how to do it. It's kind of tricky because it's a very small muscle, just lateral to the tail head and above the tail head. And you identify it by moving the tail up and down. You can feel this muscle moving. And for maximum sensitivity, you really have to get that particular muscle and do no crushing when you're getting that muscle biopsy out. So if that sounds like a lot of work, it can be a lot of work. We're happy to do it for you. There's a description of how to do it on Dr. Valberg's website, though. Okay, moving back to ENAD and EDM. So though there are low vitamin E, and there are some hallmark clinical signs that are going to raise your clinical suspicion of ENAD and EDM, this disease is clinically indistinguishable from other diseases that cause spinal ataxia, and there is no definitive antemortem diagnosis. As such, the approach to this disease should be to rule out other causes of ataxia, including compressive myelopathy, EPM, and in some cases, viral encephalitis, if it's that time of year or it's that kind of presentation. Recently, however, a biomarker called phosphorylated neurofilament has been identified to be indicative of neuronal degeneration in horses. And you'll notice I didn't say EDM or NAD specifically, but just general neuronal degeneration. It's a biomarker. What are neurofilaments? Well, neurofilaments are these structural proteins that in healthy individuals undergo very little turnover. But if there's axonal damage as a result of either a degenerative disease, trauma, or infection, these neurofilament proteins actually circulate within the bloodstream and in the spinal fluid. Biomarkers like this are really commonly used in human medicine or more commonly used in human medicine for the diagnosis of neurodegenerative diseases like ALS, Lou Gehrig's disease, multiple sclerosis, and a few others. So since this was being applied in human medicine, which is a really like a last 5 years development, we started to question whether horses have these neurofilaments and whether this could be applied for our horses. So a multi-center study was performed, compared the concentration of phosphorylated neurofilament in the serum and CSF of healthy control horses, so horses with ENAD and EDM that was verified on necropsy, and horses with spinal cord compression with pretty interesting results. So I've got one of the little diagrams there. When serum neurofilament values were compared across these 3 groups, there was no significant difference in the neurofilament concentrations. However, when a cutoff value was applied, so when they applied a cutoff value of 1 nanogram per mil, it was found that a serum phosphorylated neurofilament greater than 1 was strongly associated with the diagnosis of ENAD and EDM at necropsy. So 99% had a diagnosis of EDM and ENAD on necropsy. Important to remember that the sensitivity of this test is poor. So a neurofilament less than 1 does not rule out ENAD or EDM. Neurofilament greater than 1 is highly suspicious of ENAD and EDM. And then we also found a similar correlation in spinal fluid. So CSF neurofilament was significantly higher in both compressive myelopathy and ENAD compared to controls. And a CSF neurofilament greater than 3 was significantly associated with both of these diseases. I will say that we're just, both of these studies are pretty small. We're in the beginning of understanding phosphorylated neurofilament. I've been running it on some of my cases. Had a young horse with clinical evidence of spinal ataxia, did a serum neurofilament on it, and submitted that. And then the owner decided, well, actually, I really would like a myelogram, please. And so I'm happy to help with that. Did our CT myelogram and submitted some more samples on the horse. The lab accidentally ran both serum, so before and after the myelogram. And before the myelogram, the horse had a serum neurofilament that was consistent with ENAD or EDM. It was greater than that 1 cutoff. But after or at the time of myelogram, it was normal. I was like, oh crap, what do I do with this information? So I asked Dr. Carrie Finno, who's running this testing, and she was like, yep, probably compression. And the horse had some acute spinal cord injury immediately preceding your blood draw. And that's why the neurofilaments were high and then went down. And so this is the first one that she's known of that has a more or less definitive diagnosis of compressive myelopathy that has had a greater than 1 neurofilament. So we're still in the beginning of understanding this test. The way that I use it right now is to identify, is there active spinal cord disease? And so if the neurofilament is elevated, there's active spinal cord disease. We have to rule out, is it EPM? Is it compressive myelopathy? Or are we left with our diagnosis of exclusion? So there's a lovely flow chart here, and I included this. This is from Amy Johnson and Carrie Finno's paper on ENAD. The top part of it is blocked out, but it says neurologic signs. So don't run these tests on horses that do not have neurologic signs. Please don't run this on pre-purchases. The sensitivity and specificity of these tests are designed for horses that already have neurologic disease. Can't apply them to horses across the board. So this flow chart is kind of walks through how to do your best to rule in or rule out equine neuroaxonal dystrophy. And you see there's a lot of likelies here. Likely ENAD, cannot exclude ENAD. And that's because, again, the only way to definitively diagnose this is on an necropsy exam. So smarter people than me are doing more work in this to hopefully identify a gene that we can test horses for, ideally test the mares for, and then get ahead of this disease before it causes too big of problems. So some genome-wide studies ongoing, some RNA studies, which are pretty promising, ongoing, and hopefully we get to figure out what's going on with these horses. So while there has been a lot of work and work is ongoing, lack of our ability to diagnose this disease is a problem because unfortunately, once clinical signs of ENAD or EDM are present, they do not respond to treatment. So equine motor neuron disease will get better. Vitamin E associated myopathies generally get better. Not so with ENAD or EDM. And so vitamin E supplementation might halt the progression of clinical signs, but they're not going to reverse the clinical signs that are present. And for that reason, prevention is really key. So for horses that are at risk of ENAD or EDM, and that includes horses that are half siblings with horses that are diagnosed with ENAD or EDM, or horses that for whatever reason are held off of fresh grass pasture, they should have their vitamin E levels monitored throughout the crucial window of neural development, which seems to be about birth to 4 months and potentially up to 2 years. Mares should have their vitamin E tested and supplemented if they're low, and at-risk individuals should be supplemented or closely monitored, particularly if they're not on fresh green grass turnout. So vitamin E is crucial, and for horses that are deficient in vitamin E or don't receive turnout, they're at risk of developing ENAD or EDM. This supplementation is critical, and the type of vitamin E is very important. The expensive stuff is generally what works, and that's irritating, I know, but you really need to spend the money on this water-soluble, natural RRR alpha tocopherol. That is the most bioavailable vitamin E out there, and the only one I would recommend for horses that are actually deficient or will become deficient because they're not receiving green grass. All of the top dressings, the powdered supplements, the injectable vitamin E selenium are very poorly bioavailable vitamin E. These horses are likely not going to absorb enough to get out of a deficient state. And it's pretty remarkable. I did a little light Googling, and there are products now that are powdered that are labeled as natural, but they are not this RRR alpha tocopherol. They're not water-soluble vitamin E. They just throw the natural in front of it for marketing purposes, which is kind of irritating and disingenuous, actually. Okay, so now I was going to move on to compressive myelopathy. I know there's going to be a lot of questions about ENAD and EDM because we're just talking about it for the first time, but I'll get bogged down in it. So I think we'll move on and take those questions at the end. So I'm not going to do a lit review on this disease, but I am going to discuss the diagnostic options. So up until very recently, contrast cervical myelogram has been the gold standard for the diagnosis of cervical spinal cord compression. Really well-described technique, relatively well-established cutoffs for compression, though there is some subjectivity to interpretation of the myelogram. Another benefit of the myelogram is that we can identify dynamic compression by flexing and extending the neck and then taking those radiographs. Additionally, this is a really fairly well-tolerated procedure. Every now and then you've got a horse that has a seizure after the myelogram because of the contrast agent or has a little hyperthermia or neck pain, but generally these horses do just fine. However, the limitations of the myelogram, the most important limitation of the myelogram is that we are only seeing dorsal to ventral compression. So our middle-aged to older horses or our young horses that have developmental disease and enlargement of the articular facet processes, we aren't identifying any spinal cord compression using just our lateral myelogram. Additionally, we're often making life or death decisions for these horses, or at least life-altering decisions for these horses based on the results of our myelogram. And the sensitivity is really pretty crummy at like 76%. I mean, that's not ideal. As I said, we can only identify compression from dorsal to ventral. Here's a horse with a flex neck, and you can see some evidence of spinal cord compression. Here's in the caudal cervical spine. We've gotten really good and have nice technique now for getting down as far as C7 to T1, which is really lovely, but again, can only see that dorsal to ventral compression. And here's where the CT comes in. So our CT scanner has been a really incredible diagnostic aid for horses, and it allows us to see a three-dimensional view of the head and the neck. Motion and anatomy do really limit our imaging capacity right now in the standing horse for the neck. Really good at heads. The neck still leaves something to be desired. We are going to be testing out a new addition to the front end of our CT machine that might allow us to do a little bit better on the standing horse for the neck. However, for my cases, CT under general anesthesia is where it really shines. But here's a couple of images that were obtained in the standing horse. So here we've got a horse head. I'm looking for evidence of guttural pouch disease or temporal hyoid osteoarthropathy, and I can clearly see the temporal hyoid joints here. So that's really nice. This is the standing horse. You do see some motion artifact, but it's not too bad. This is, again, a standing horse, C1, got some motion artifact, but enough to see this little fracture coming off the C2, which was pretty diagnostic. In a lateral view, you could tell something was happening, but you couldn't really tell how far that was extending ventrally and how much the fracture was displaced. Here's the type of image that we can get in a nice horse that's standing still. I think this is C4, I want to say. I'm not 100% on that. But you can actually see the articular facet joint. And this is where the spinal cord would live. And if there's any osseous proliferation here, that could be compressing the spinal cord. And we might see some evidence of spinal cord impingement even in the standing horse. So great with heads. Necks and the standing horse, we can get better at. But man, an anesthetized CT myelogram gives us a lot of information. So here's one of our horses that's had a standard myelogram. Now taking him into the CT, we can get down to C6, C7 in the majority of horses. Every now and then we can get down to C7, T1. And it gives us a lot of information. So here's a regular lateral view. However, I can see, which I couldn't identify on the myelogram, some fragments coming off of this caudal vertebral end plate. And the amount of detail we see with this little boop, I mean, it's pretty incredible what you can get with the CT. Because we're doing a CT, we can get a three-dimensional view of the neck, which we've never seen before. That allows us to see, again, that lateral compression, and we can quantify the degree of compression that's happening. Also lets us see vertebral disc disease, which we couldn't identify before, complex fractures, if there's a hematoma or a tumor within the vertebral canal, we can identify that as well. And so this is one of the more common lesions that we see. This is a young warm blood, young to middle-aged warm blood. We've got the spinal cord here in black. We've got our contrast around it in the subarachnoid space. And you can clearly see this articular facet, osteoarthritis or degenerative disease that's impinging and compressing on that spinal cord. And man, it's just so nice to have this piece of information. There are very few horses that walk away from a CT myelogram that we don't, we feel confident if there's going to be disease there, we're going to see it. And that's just a really great feeling. Myelograms, you're like, well, I don't see anything, but it doesn't mean it's not there. This diagnostic, we can tell if it's there, we'll find it. And we are left with a few more questions, though. We see this beautiful detail. We can definitely know what compression is, but what about when there's just impingement? So there's no obvious decrease in the lumen of the spinal cord, but there seems to be less room for the spinal cord to move around. What does that mean? I did a research study on this, and I need to get my data together and publish it. But we're establishing normal reference intervals for non-neurologic horses. And I'm hopeful that those normal reference intervals will help us determine a little bit better how much impingement is abnormal, what's the normal size of the vertebral canal. I'm really excited about publishing this information. Okay, moving on to Lyme disease. I should say, Dr. Erskine will like me to mention this, we're currently the only facility doing a contrast CT myelogram on the East Coast. So you can send them to Kentucky, but in Virginia and in the East Coast, we're the only ones who can do a contrast CT after our myelograms. Okay, neuroborreliosis. Oh man, talk about a can of worms. Neuroborreliosis is a real pain. And I'd like to be clear with the next few slides, I'm not talking about Lyme disease in general. I'm talking about Borrelia actually infecting the spinal cord, the brain, or the meninges, so specifically neuroborreliosis. And I'm not referring to kind of nebulous ADR, body soreness, low-grade clinical signs. I'm referring to actual bacterial meningitis. And even though it's actual bacterial meningitis, the diagnosis of neuroborreliosis or Borrelia burgdorferi as a cause of this meningitis is really difficult. The diagnostic tests that we perform are only antibody tests. And as you know, exposure to Borrelia is really high, 77% in the Northeast. A study about 10 years ago now showed about 30% of horses in Virginia were positive for antibodies to Lyme disease. And so, with the prevalence being that high, it's hard for us to tell, are these antibodies at all associated with clinical signs? So for a diagnosis of neuroborreliosis, these horses must have clinical signs of meningitis. So that's a history of a fever or a low-grade fever, maybe a higher fever. They typically have clinical signs of neck pain. So they have a low head and neck carriage, maybe they're lethargic, and they're often painful on flexion of the neck. If we do a CSF tap, which we need for a positive diagnosis, these horses have an elevated total nucleated cell count in their CSF, and then typically the neutrophils are elevated. And frustratingly, antibody titer can be really variable in these cases, and I'm going to show you that in a study that Dr. Amy Johnson did in the next few slides. So her title says it all. Cerebrospinal fluid Lyme multiplex assay results are not diagnostic in horses with neuroborreliosis. I mean, that really says it all. So she took a couple of different groups of horses, some being neurologically normal, some with other neurologic diagnosis, and some being healthy, and performed this retrospective study looking at their serum antibody titer and then their spinal fluid antibody titer. I think everyone here is probably familiar with that multiplex antigen assay. got OSP-A, which is supposed to show us acute disease, OSP-C, or vaccination, I guess I should say, vaccination or acute disease, OSP-C, which is early to mid infection, and then OSP-F, which is supposed to be chronic infection. She included 90 horses in this study. These horses all had neurologic exams. They had serum and CSF LAIM multiplex assays, and they all had a post-mortem exam of the CNS. Antibody concentration was compared in the serum and spinal fluid, and a ratio of greater than 4 was considered evidence of intrathecal antibody production, so actual antibody production within the spinal fluid. Back in action. So either of these tests are good for the diagnosis of EPM in horses. Really need that CSF to confirm it though, because of the high seroprevalence. It's important to note for the UC Davis test, they've got some really interesting statistics that say if the serum titer is over X amount, then the chances of EPM are 90%. Those statistics only work for horses in California, not for horses in Virginia. So they are based on the population that's in California and on the seroprevalence in California. Those numbers do not work for Virginia horses. Both of those tests are good, but you cannot trust those percentages when applied to horses in Virginia. Okay, need spinal fluid to confirm a diagnosis of EPM. A negative serum titer generally, in 99% of cases, rules out EPM. So what did I want to say about this? So serum titer alone is not a great indicator of whether or not a horse has EPM. Even if we apply these cutoff values, the sensitivity is not great. So for something like EPM, you want to make sure that you have a high sensitivity and that you catch all the horses that actually have EPM, but you also want to have a fairly high specificity too, because treatment's expensive and you want to make sure you're treating for the right disease. And so even when we use a high cutoff titer or a low cutoff titer, let's say we say horses with a serum titer greater than 500, we're going to call them positive for EPM, and this is serum only. The sensitivity is good, but the specificity is pretty crummy at 37%. So there's a pretty decent chance that this horse actually has another disease that's not EPM. So using the serum titer alone is not super helpful to confirm a diagnosis of EPM. Even using the CSF titer alone, it's a little bit better, but it's not enough on its own to have a great sensitivity and specificity for confirming the diagnosis of EPM. Instead, what we do is a serum to CSF ratio. And then we know if the cutoff is greater than a certain amount. So we compare the amount of antibody that's in the blood to the amount of antibody that's in the spinal fluid. And if the amount of antibody in the spinal fluid is relatively greater, then we can say with a pretty good certainty that this horse actually has EPM. Now, I will say if we're too rigid about these cutoff values, we might potentially miss a few horses. And so we generally use a cutoff of 100. The sensitivity is good at 93%. Specificity is really good, really pretty good at 83%. Having said that, there is going to be a case here and there that might actually have EPM that doesn't meet this criteria for the cutoff. So if I have a case that gives me borderline titer results, clinically looks like EPM, I'm going to go ahead and treat for it because better safe than sorry with EPM, right? You don't want to get behind the 8 ball on treating for that disease. We do have a new diagnostic that might be helpful in some of these borderline cases. This is a study that I worked on with some colleagues out of Blacksburg as well as across the country. And we checked on this serum inflammatory marker, soluble CD14, compared healthy horses with those with EPM, and did find that the CD14 was significantly elevated in horses with EPM compared to the control horses. Having said that, you can see that there's a lot of overlap here, right? So if you get one that's high up here, and you've got a borderline serum to CSF titer ratio, that might help point you in the direction of, yeah, I definitely think this is EPM, but there are still a lot of overlap between these EPM and control cases. Okay, so let's move on to the really important stuff, treatment. So there are 3 FDA approved drugs for the treatment of EPM. It's Rebalance, Marquis, and Protozil. Rebalance, obviously, it's been around the longest. It's a sulfa drug recommended to be given once daily for at least 6 months for the treatment of EPM. So at first glance, obviously, this drug seems like the cheapest option if you're just looking at the price tag. But for the duration of time that it needs to be given, that price obviously goes up. Additionally, the bioavailability is affected by fasting. And so the numbers that you get in the pharmacokinetic study were done on fasted horses that hadn't eaten for a couple of hours before receiving the drug. Those numbers can't be applied to horses that haven't fasted, which is not really doable for a lot of people on a daily basis for 6 months. This drug does exceed inhibitory concentrations for sarcocystis quickly, but there are large fluctuations in the peak and trough values, meaning that the drug doesn't stay above inhibitory concentrations for the whole dosing interval. And additionally, anemia and pancytopenia has been seen with long-term administration of Rebalance, as well as colitis when other antibiotics are added on top of Rebalance for, let's say, a laceration. Then we have Marquis. Marquis is our tried and true drug for the treatment of EPM. To reach a steady state faster and to stay above the minimum inhibitory concentration for sarcocystis, it's recommended that you give a loading dose of 15 mg per kg. So for your average horse, that's a 3,000-pound dose, and give that initially, and then go to the regular recommended dosing. We also know that absorption of Marquis is improved with the administration of canola oil. And so that's one way that you can maximally get absorption of that drug. Feed the horse a little Equine Senior or what have you with about a quarter cup of canola oil on it, and then give the Marquis. Then we've got our diclazuril, which is Protozil. It's been on the scene for a while. It's in the same drug class as panazuril. It is a pelleted formulation, though, which is really handy for horses that are not great for oral medications. It's also my drug of choice for horses that I have that are dysphagic as a result of EPM, because the Marquis adheres to the plastic tube if I have to have a nasogastric tube in to get medications and feed into a horse. So I'll use it for that. Additionally, and importantly, Protozil requires no loading dose, which makes it more cost effective. The FDA approved dose of Protozil is 1 mg per kg daily, and that's the dosing strategy that's on the label. However, there are some alternative dosing strategies that I'll discuss that have been pretty well researched. These dosing strategies can be quite useful for cases where the administration of antiprotozoal meds needs to be prolonged. I usually treat these horses for at least 2 months. Or if you're attempting to prevent a relapse of EPM during a stressful circumstances. The first alternative dosing strategy is the administration of a 0.5 mg per kg daily, half the labeled dose. And this figure is from the paper comparing the pharmacokinetics of 1 mg per kg and 0.5 mg per kg diclazuril daily. Researchers found that while giving half a dose of Protozil did result in slightly lower plasma concentrations than the full dose of Protozil, even a single dose did reach the minimum inhibitory concentrations of 1 nanogram per mil, or on this chart, 0.1 micrograms per mil, which you can see it's way here on the bottom of the y-axis. So even at the 0.5 mg per kg dose, we're well above that minimum inhibitory concentration in the plasma. But who cares about plasma, right? We need to know about spinal fluid. That's where the organism is. It's in the central nervous system. And so we need to know what the concentration is there. So this chart is from the same paper comparing CSF and plasma concentrations at the 2 different doses. And you can see that while the plasma concentrations are quite different, the CSF concentrations are actually really similar. And importantly, both are far above the MIC of 1 nanogram per mil. So it seems that both dosing strategies, the full 1 mg per kg and the 0.5 mg per kg are good options. Another alternative dosing strategy that's been explored is a 0.5 mg per kg every 3 to 4 days, so every Monday and Friday. This was primarily explored as a preventative strategy to prevent seroconversion to sarcocystis positive. But they did find that giving horses a 0.5 mg per kg every 3 to 4 days did also result in steady state concentrations above MIC for sarcocystitis. So this might be a good option for a horse that just really needs the prolonged treatment, or if you had a horse that's back in work, now they want to travel, they're going to trailer here or there, they're going to get some steroid injections in their hocks. Maybe you need to put them on Protozil Monday and Friday to try and prevent relapse of EPM. Okay, finally, last topic I'd like to discuss is spinal taps, because I've been harping on how important they are to get spinal fluid to test for all the various diseases that we've discussed. For the last several years, we've integrated this C1, C2, or atlantoaxial CSF tap site into our practice. This is a pretty straightforward and reliable method to obtain a relatively large volume of spinal fluid with minimal blood contamination. This is an ultrasound guided technique that does require a little bit of knowledge and dexterity to be performed. So here I've got a slide, the subarachnoid space is there, the spinal cord is there. So important to note, when you're doing a lumbosacral tap, there's no spinal cord there. We've got spinal nerve roots, but no actual spinal cord. There is actual spinal cord on the C1, C2 space. And so we use our ultrasound guided technique to make sure we're puncturing the subarachnoid space, but not advancing our needle into the spinal cord. I've heard some anecdotal stories of that happening, and those horses were okay. But this is certainly a higher risk procedure than doing a lumbosacral tap, and we want to make sure we're really well trained to get it done. Additionally, since integrating higher risk, and then additionally, the C1, C2 tap does have post-procedure pain and discomfort side effects that we don't generally see with our lumbosacral taps. So if I have a horse that I'm doing a C1, C2 tap, I send them home on Flunixin twice a day for a couple days, tell people to keep an eye on them and keep their heads elevated. So don't feed them off the ground. There are some reports of horses getting hyperthermia after a C1, C2 tap. It's thought to be a response to blood within the subarachnoid space and not an actual infection. Those horses have reportedly done really quite well with no long-term complications, but it's a little bit higher risk than our lumbosacral taps for sure. And then I've often wondered, does location of your CSF tap matter? We know that fluid from the lumbosacral space generally has more protein in it than the atlanto-occipital space, and I presume that that's true for C1 and C2, but we really didn't know until a group from NC State took samples of fluid from the lumbosacral space and then the C1, C2 space and compared them. And they found that in cytologically normal samples, there was some significant differences. The total nucleated cell count was slightly but significantly higher in C1, C2, and LS samples than the nucleated cell count from the AO space. Additionally, protein was significantly higher in lumbosacral fluid compared to C1, C2, and AO fluid. So protein's higher for lumbosacral space. Our antibody is going to be higher too. That's the ultimate question, because a lot of our testing that we're doing for EPM, plus or minus Lyme disease, are antibody tests. This research has been done, but it's not a complete study. So research team led by Dr. Furr compared cytologic findings from Sarcocystis neurona titers and CSF taken from the C1, C2 and the LS space. They found what was confirmed in the previously quoted study: fluid from the lumbosacral space absolutely has more protein in it. However, they found no significant difference in the EPM titer values, though notably, none of the horses in this study actually had EPM. And so it's uncertain if you're going to get, our titer cutoffs, our cutoff ratios are so narrow. If you have even one dilution of difference, then that could place a horse as positive for EPM versus negative for EPM. And so, for example, if you get, a 1 to 40 in the lumbosacral and a 1 to 20 in the C1, C2 space, that could be enough to differently characterize this horse. So given that information, which is so far a bit of a lack of information. Our general approach is we try and get spinal fluid from caudal to where the clinical signs are. And so if a horse has ataxia in all 4 limbs, then we're going to try and get that fluid from the lumbosacral space. However, some horses' behavior, anatomy prevents us from getting that spinal fluid. In those cases, we've got the C1, C2 site, which is probably just as good. But we generally try and get it from the lumbosacral space first. This slide will be saved online for anyone who wants to look at it. And it's a reminder that though these diagnostics are really important, there's nothing more important than a good neurologic exam that has a neuroanatomic localization. And so I just included this slide as a description of where you would see with different lesion types, what type of clinical signs you would see as a reminder. Okay. Happy to answer any questions now. I usually get harassed about Lyme disease. I've just been waiting for it. Maybe the break threw everyone off.
What do you consider the vitamin E, the normal range testing for vitamin levels?
That's a great question. So the question was, what's the normal range for vitamin E? And my answer is a little roundabout. Taking the sample and good sample handling is really important because vitamin E is actually pretty labile. So it's recommended to take blood into a green top tube, protect it from light. I usually put it in a glove and then refrigerate it until it's shipped. Even though I'm on the East Coast, I generally send my samples to UC Davis because they've got the most recent validation of their vitamin E testing and the best reference intervals. And for them, greater than 2 is considered normal. And they've got some kind of goals for different age groups identified too. So I find their reference intervals really helpful. A lot of people around here send to Cornell University and they've got a great diagnostic lab. But interestingly, their units, when translated to the UC Davis units, their reference intervals don't match. And so when I asked them in the lab a little bit more in depth about this, realized that their reference intervals haven't been updated for a really long time. And so as I'm not familiar or comfortable with that, I send mine to UC Davis.
So I'm confused about Lyme. So neuroborreliosis is really not diagnosable. I mean, you can't confirm it. You can't confirm any of these things. You can't confirm that based on CSF, serum, titer, comparison. Agreed.
So neuroborreliosis cannot be confirmed by the presence or absence of antibodies in the spinal fluid. What I use and surely neuroborreliosis is out there. We know it's out there. So what I use in the alive horse to tell me that it's likely neuroborreliosis is a spinal tap that has elevated white cells and primarily elevated neutrophils. And then I often will send that fluid for PCR. I've occasionally gotten a positive, but I'm really excited about the new testing because I think we're going to get more and more positives. And then additionally, I will treat these horses with tetracyclines. If tetracyclines have already been tried, I sometimes try K-pen at higher doses than normal or on a CRI. True neuroborreliosis can be really pretty devastating. A lot of these horses also have undiagnosed immune deficiencies and aren't producing antibodies the way they should, which is maybe why they don't have that antibody response within their spinal fluid. Yeah, it's tricky. Yeah. And then there's these nebulous, I think this might be Lyme disease. They've got a low-grade fever, they're lethargic, they're touchy, they're not quite right. They're minocycline, doxycycline, or oxytet responsive. What do these horses actually have? That's a great question. But I challenge us all to not, to make Lyme disease a diagnosis of exclusion and remember to rule out, some of the other things that could be progressive if they're not treated appropriately.
So neutrophil in the CSF.
Mm-hmm. Yeah. There's been reported, I mean, even 15 or 20 total nucleated cells, that can be neuroborreliosis. Sometimes you get some that are 100,000, 20,000 white cells, and that's pretty remarkable. Yeah.
So,
yeah.
But I've not seen figures, I've not seen white cell shifts, blood, CSF tabs. I don't think we recognize that those low. Look at it and you think maybe.
Yeah, I've had a couple of, I just call them oxytet responsive meningitis, and they've got, this kind of low grade inflammation in their CSF. Maybe they've got, 8 to 20 total nucleated cells per microliter. So more than they should, but not remarkably more. And I presume they're probably Borrelia, but I don't know that for sure. And New England's a lot different than Virginia too. It's just different prevalence of disease there too. Yeah.
I know it's not exactly your topic, but David, would you make a comment on diagnosis of Lyme disease versus non-neuroborrelia?
I don't know. Yeah, I really don't know. There's a consensus, an ACVIM consensus statement on Lyme disease in horses. And like a lot of consensus statements, it gives a lot of answers, but it also has a lot of questions. So a horse, and the problem is too, is because we've so far not been able to establish disease in a horse, right? So the Cornell team's done the most work. They had a bunch of ponies, they infected them with Lyme disease. They didn't cause any damn clinical signs. And then they actually were able to harvest the Borrelia from different, from the spinal nerves, from the joints, from things like that. But they couldn't cause any clinical signs in these ponies. And then we've got some other ones that probably really truly do have Lyme disease. And I think it's really hard to differentiate those two. So to answer your question, I do a comprehensive exam and blood work. And if I've got, ADR, fever, a neuropathy, kind of behavior change, muscle soreness, but don't have liver disease, don't have PSSM, don't have low vitamin E, I try and rule out other things before I, pin it, before I do more than one round of tetracycline antibiotics.